Hello, 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 ladies and gentlemen, and welcome back. Welcome back from spring break. If you are listening to this after break, I hope you had a great break. I hope you're feeling rested. I hope you are feeling fresh and ready to get back to work. Today we are talking about biliary and pancreatic disorders. For the learning outcomes for this information, we are going to correlate clinical manifestations to the pathophysiological processes of cholecystitis and acute pancreatitis, and we will be discussing the medical management of those same disorders, cholecystitis and acute pancreatitis. So we will develop a comprehensive plan of nursing care for patients with biliary, and pancreatic disorders because we are nurses and that's what we do. And we will also design a plan of care that will include pharmacological, dietary, and lifestyle considerations for patients with biliary and pancreatic disorders. So, the biliary system. The biliary system includes the gallbladder and the bile ducts. The cystic duct, which is coming from the gallbladder, and the hepatic duct from the liver will join to form the common bile duct. So, the primary purpose is to transport bile from the liver, where it is made, to the gallbladder, where it is stored, then on to the duodenum, where it will aid in digestion of fats. And bile is the digestive enzyme that will help to break down these fats. So biliary disease will occur when the gallbladder or the ducts become inflamed, infected, or cancerous. So we're going to start with cholecystitis. Cholecystitis is an inflammation of the gallbladder due to the obstruction of bile flow. So because it's inflamed, we've made it angry. We've done something to piss off the gallbladder. Or there may be some sort of obstruction like a stone. So there are two classifications. Calculus cholecystitis, where there is the presence of stones, or acalculous cholecystitis, which is without stones. And these gallstones are hard deposits that are formed from bile contents, often causing obstruction of the ducts in and around the gallbladder. And this is what we call cholelithiasis. The gallbladder is angry. It is inflamed. The incidence of cholecystitis will increase with age, and these gallstones are more common in women than in men. So please keep in mind the 5Fs. The 5Fs are fair, fat. You are female, you are fertile, and you may be over 40 years of age. They are the 5Fs, ladies and gentlemen. So let's think about some risk factors now. So obesity, or the other side of the coin, which would be rapid weight loss, both are risk factors for cholecystitis. Weight loss surgery is a risk factor for cholecystitis. Eating large amounts of foods with saturated fats will make your gallbladder angry. Pregnancy will inflame the gallbladder due to the elevated progesterone level. Ladies and gentlemen, listen up, and then listen up one more time. Pregnancy will inflame the gallbladder due to elevated progesterone levels. Genetics will play a part in this, and some medications. Estrogen and cholesterol lowering medications will also play a part in inflaming the gallbladder. But one of the more common reasons for females is pregnancy. and it is due to the elevated progesterone level. So gallstones present in 3 categories. Cholesterol stones, and these are the most common type. Pigmented, and these are formed from that excess bilirubin. And then there are mixed stones, and this is a combination of both cholesterol stones and pigmented stones. These stones will vary in size, and a patient may have 1 stone or they may have multiple stones. So, choleductolithiasis is when there are gallstones blocking the common bile duct or the cystic duct. The sphincter of Oddi will control the release of digestive enzymes into the duodenum, and this happens in response to oral intake. Okay, so we eat something, the body releases the bile, but it is the sphincter of Oddi that controls the release of this bile, these digestive enzymes, to help in breaking down and digesting food. So the sphincter of Oddi may contribute to biliary stasis. And then there is the cholecystokinin. And this is a peptide hormone that when activated after eating will cause the gallbladder to contract and release the bile, leading to biliary stasis. So the way this goes is that you will eat something, there's oral intake, the cholecystokinin, the peptide hormone, is activated, which is going to trigger the sphincter of Oddi to release those digestive enzymes. So, some clinical manifestations. There may be none. There may be no physical findings whatsoever, not for the longest time. There may also be pain and tenderness in the right upper quadrant due to the release of this cystokinin causing the gallbladder to contract. So then this pain can be colicky. Colicky means that it is intermittent and it will radiate to the back. And this pain is related to the movement of the gallstones through the bile duct as the bile flows. There may be rebound tenderness or guarding. Your patient may have a fever. Because of the fever, they may have tachycardia. They may also be positive for Murphy's sign. Murphy's sign is pain on palpation of the right upper quadrant upon deep inspiration. Now, this is not to be confused with appendicitis. When you have appendicitis, you have rebound pain, and that is when we press on the abdomen, and then there is pain when we release. With Murphy's sign, there is pain on palpation upon deep inspiration. So as I'm going in, as I am palpating deeper and deeper, the patient will feel pain. All right, diagnosis. How is doctor going to diagnose cholecystitis? Well, let's see. We can do an abdominal x-ray, and with the x-ray we can detect these calcified gallstones. He may order an ultrasound. An ultrasound is a non-invasive test that is used to determine the presence of gallstones or positive for cholecystitis. Or he may order a CAT scan. A CAT scan will visualize the entire abdomen and can detect the presence of gallstones. So he also may think about a HIDA scan, a hepatobiliary aminodiactic acid scan, a HIDA scan. This is done in nuclear medicine, and it is to study the production and flow of bile. It will visualize the liver, the gallbladder, the bile ducts, and the small intestine. Doctor may also order an ERCP, an endoscopic retrograde cholangiopancreatography, an ERCP. and this will visualize the common bile duct where gallstones can be removed. So it is during this ERCP when doctor is going in and visualizing anything. If the gallstones are visualized and if they're small enough, they may be removed at this time. So therefore, there is no eating or drinking the night before the procedure. Your patient will be NPO after midnight. However, they will be able to take their cardiac and blood pressure medications in the morning of the procedure with a sip of water. Your client will be sedated for the ERCP. Post ERCP, we are going to observe the patient for a potential systemic inflammatory response syndrome, otherwise known as SIRS. And this is caused by the manipulation of the bile ducts and the potential bacterial translocation. Because remember, if everything is angry here, it could be angry and inflamed due to bacteria. So when doctor is in there with the scope during the ERCP and he is poking around and possibly trying to remove those stones, what could be happening is that inadvertently, not on purpose of course, he can somehow translocate some of this bacteria. And then there is the cholangiogram, and this is commonly used in the operating room to image the biliary tree. So doctor may order some lab studies. One of the things that we may see is an elevated white blood cell count and elevated WBC, and this will be due to inflammation. And then we are going to look at those liver enzymes, the AST, the ALT, the LDH, and the ALP. And these will all be elevated because of the blockage of bile flow to the bile ducts. So treatment. Lithotripsy. Lithotripsy is when shock waves are used to dissolve gallstones. Or doctor may choose a laparoscopic surgery, a lap chole it is referred to as. And ladies and gentlemen, listen up, and then listen up one more time for me. The laparoscopic surgery is the preferred method of intervention for these gallstones. It is the preferred method. It is the method of choice to remove the gallstones. Lithotripsy, not so much anymore. Laparoscopic is the preferred method. So some medications. Let's talk about medications. Your client, your patient is going to be NPO. That is nothing by mouth, NPO status. And this will prevent the release of the cystokinin. Now remember, we just said that cystokinin is that peptide hormone that that starts everything off, right? It's what initiates the sphincter of Oddi to release the bile. So by making our patient NPO, nothing to eat or drink, then nothing is activated. The cystokinin will not be activated, and so therefore the gallbladder will not cause to contract. There will not be bile released, and then there will be no pain. So that is why we make the patient NPO. Because your patient is NPO, they will be on IV fluids. There will be IV hydration. We are going to look at fluid and electrolyte imbalances, and we will be able to correct those fluid and electrolyte balances with IV fluids. We are going to look at pain management. Sometimes this is very, very painful. Cholelithiasis in these gallstones can be very, very painful. So we are going to take into consideration pain management. Doctor may order IV antibiotics. It will be a very short course, maybe 1 or 2 doses of IV antibiotics, and it will be a broad spectrum antibiotic. So, ladies and gentlemen, medications. Morphine. Morphine is usually contraindicated for pain management as it can cause the sphincter of Oddi to spasm. and that is going to result in pain for your patient. So morphine is contraindicated for this population because it's that sphincter of Odie that causes your patient pain. So we will use other narcotics for severe pain management. We can also use acetaminophen or NSAIDs such as ibuprofen, naproxen for pain management that is not as severe. And we may also use oral agents to dissolve the gallstones such as Actigol. Patients may take these oral medications for up to 2 years, and that can be very expensive. And the medications that I'm talking about are the oral agent medications to dissolve the gallstones. So if the patient stops taking these medications, the stones will reappear, and then the problem continues. So because treatment is prolonged, many patients are non-compliant with this therapy because the treatment is very, very extensive, 2 years worth, and also expensive. So diet nutrition is going to play a very huge part in this disorder. Foods will contribute to the formation of gallstones, and some of these foods should be avoided. And they are fatty foods such as fried foods, ice cream, dairy products, red meats, and then heavy alcohol. All of the things that we really enjoy, right? So therefore, patients should be choosing foods that are low in saturated fats, such as rice and whole grains, potatoes, pasta, yogurt, fruits, and lean meats. There are several surgical options for treatment of cholecystitis, and this intervention will be dependent on the patient's presentation and the severity of the clinical manifestations. And then, ladies and gentlemen, listen up for me, and then listen up one more time. The standard surgical intervention is a laparoscopic cholecystectomy, something that we call a lap chole. This is the preferred surgical intervention. If the patient has complications such as a perforated gallbladder or peritonitis, then an open surgical procedure will be indicated, but that will be the surgeon's choice. An open cholecystectomy may also be indicated if the patient has a history of previous abdominal surgeries, because there will be scar tissue in the abdomen that we will have to cut through, or if the patient is morbidly obese. If stones are present in the common bile duct, a surgeon may place what we call a T-tube. It is a biliary drainage tube into the common bile duct to monitor bile drainage. And this tube may stay in place for up to 2 weeks after surgery. So therefore, nursing will need to monitor the output from this tube. Bile output should not exceed 500 milliliters in the first 24 hours. If it does, you are going to have to notify the surgeon. So the laparoscopic cholecystectomy. There will be several small incisions in the abdominal cavity, and then carbon dioxide gas is going to be inserted to create space in the abdomen. We are going to move the other organs so that we can visualize the gallbladder on laparoscope, and then, or fluoroscopy, and then the laparoscope is going to be placed through the incisions to remove the gallbladder. This is done under general anesthesia. It can be done on an outpatient basis, or it may require just an overnight stay in the hospital. The patient after the surgery will recover from anesthesia in the PACU, that is the post-anesthesia care unit. The nurse will monitor vital signs, pain, their neurological status, because after all, they did have general anesthesia. We are going to monitor for nausea and vomiting. You do not want your client to be nauseous, and you certainly do not want them to be vomiting after they just had this abdominal procedure. and we will be looking at the incision for signs and symptoms of distension. Now, some distension will be appreciated, and it would be what we call quite normal, because we did insert carbon dioxide gas into the abdominal cavity so that we could visualize the gallbladder. The nurse will also monitor for bleeding and bruising. Now, some bruising, because of the trauma to the abdomen, will be expected. So we are looking at bruising that could be a little bit more trauma than what would be expected. So when the patient is awake and following commands, clear liquids may be given in small amounts. And then after the first 12 hours of liquids, if there is no nausea, no vomiting, or abdominal cramping, then we can begin small amounts of solid foods. These foods will be low fat. And then discharge instructions. Your patient is going home. They need to know incision care, how to change the dressing, but the dressing will stay in place for the first 24 hours. Sometimes underneath the dressing, the surgeon will use Dermabond. This is like a glue, like crazy glue, and he will glue the incision shut, and the incisions will just heal, and then that will be that. Sometimes they will use sutures or staples, and they will have to come back and have those removed. They need to know to recognize signs and symptoms of infection and then signs of jaundice, because sometimes jaundice will occur. And so therefore we need to teach them signs and symptoms of infection. Elevated temperature, elevated heart rate. The area around the incision, is going to appear red or hot. We need to talk to them about pain management, and because we're talking to them about pain management, we need to talk to them about constipation prevention. So we need to talk to them about stool softeners, mobility, and this would be activity level as tolerated. There really can't be any pushing, pulling, probably no driving for a small bit of time. And certainly no driving while they are taking narcotics. So we will also instruct the patient on showering. So when they are in the shower, what we want them to do is we do not want them to face the shower head. We want them to turn around, and so that their back is facing the shower head, so that the water can flow down the front of their body and there is no water pressure on the incisions. No pool, no tub bath, no hot tub for up to 1 week post-op. They need to know if they are going home with the T-tube, because remember, this T-tube can stay in place for up to 2 weeks. So the client or the client's family may be caring for the T-tube, so they need to know how to assess the drainage. It needs to be green. The consistency, sometimes bile is a little on the thicker side, and they need to know about the correct amount and when to call doctor. They need to know how to empty the contents of the drainage bag. They need to know about skincare around where the T-tube is inserted. So you will need to give them all of this patient education. Now, that is not to say that if they do go home with this T-tube, that a home care nurse may not be visiting the home, but the family also needs patient education. So patient education will include care of the T-tube, assessing the biliary drainage, assessing for signs and symptoms of an obstruction. They need to monitor their color of their urine and their stool. We want to make sure we're not seeing clay-colored stools. And they need to know signs and symptoms of infection. You will give them all of this education before they leave. However, after an open chole, well, that involves a little bit more care. We are also going to monitor vital signs and pain, and because it is general anesthesia, we are also going to monitor their neurological status. Again, we are going to assess the abdomen for signs and symptoms of distension. And again, some distension will be expected. It would be the norm. We are also going to assess for bleeding and bruising. And again, some bruising because of the trauma to the abdomen is going to be expected. These patients, however, will not receive liquids until they are passing gas. They need to pass flatus. So we also need to be assessing this abdomen for bowel sounds, because you're not going to give anybody anything unless they have bowel sounds. The diet will be advanced to regular if there is no nausea, no vomiting. We will continue to manage their pain because this is an open incision. We need to encourage coughing and deep breathing because we want to prevent that pneumonia and that atelectasis that comes with a general anesthesia and an open surgery. We need to encourage that walking, not only to help with the constipation, but also to help with the passing of the gas, because these clients may have gas pains. And sitting up in bed in a chair. Sitting out of bed into a chair to prevent the pneumonia and the atelectasis as well. So, discharge teaching for this open cholecystectomy. What are we going to talk about? Again, we need to educate the patient on the signs and symptoms of infection, monitor the fever, monitor the incision site, monitor any drainage. Preventing this constipation, they need to be able to walk around a bit, maybe a gentle laxative, lots of fluids. We're going to encourage low-fat diet. We're going to talk about activity as tolerated. And again, even with an open chole, there is the possibility of a T-tube. And so again, that same education will apply. If a T-tube is present, they will need education regarding care and management. So nursing management, the most common complaint will be abdominal pain. So we're going to have to manage their pain. This pain may be described as colicky, intermittent, and then radiating to the back. The physical exam will include right upper quadrant tenderness. They may have a fever. They may have an elevated heart rate because of the fever. And then pre-surgery, they may have a positive Murphy sign. They may have elevated liver enzymes, a bilirubin, and WBC due to inflammation. So we are going to have to assess their labs. So some nursing diagnoses are acute pain related to obstruction and edema related to gallstones, fluid volume deficit related to nausea, vomiting, and increased fluid loss, imbalanced nutrition, less than body requirements related to nausea and vomiting. And then, as always, there is a knowledge deficit because there is a learning need. So it will be knowledge deficit regarding their condition, their prognosis, the treatment regimen, how to care for themselves after this episode, whether it is a lap chole or an open chole, and then whatever their discharge needs are. So nursing interventions, we are going to assess because we are nurses and that's what we do. We are going to assess vital signs. Fever and tachycardia may be due to the inflammation if gallstones are present. They may have an elevated respiratory rate if they are feeling anxious or if they are in pain. Their blood pressure may be low if they are dehydrated, or it may be part of the inflammatory response. Their pain, we need to assess their pain, the onset, the duration, what makes the pain worse. Is there anything that makes the pain feel better? They need to be able to describe the pain. Is it intermittent? Is it colicky? They may have severe pain in the epigastric area and right upper quadrant that radiates back to the back. We are going to assess their abdomen. We're going to assess for distension. We're going to assess those bowel sounds. Do they have a positive Murphy sign? We are looking at those serum electrolytes. They may be imbalanced due to dehydration from nausea and vomiting, or because of lack of appetite. So there will be lack of PO intake because of the nausea and vomiting, and because they are just feeling so awful, they just may have a decreased appetite. We are looking at the WBCs. The WBCs may be elevated due to the inflammation. Again, we are looking at those liver enzymes, the bilirubin level. This may be elevated because of blockage due to the bile flow in the bile ducts. We are looking at their skin turgor. Their skin turgor may indicate dehydration. If able to, or the client may be able to, monitor their stools. Their stools may be clay colored, and this is going to be due to the lack of bile. We are going to monitor their daily weight. Are they dehydrated? Are they holding on to fluid? And their edematous. Of course, they're going to be on I&O. We're going to be looking at their fluid volume status, again, to assess dehydration or fluid overload. We're looking at their nutritional intake. Their nutritional intake is going to be very, very important with this disease process. So we are also going to look at their dietary history, their fat intake, any foods that will contribute to this happening again. Because if they have developed gallstones once, then we know that they are at risk to develop gallstones again. So nursing actions, what are we going to do? We are going to administer analgesics as doctor ordered. However, we are not going to use morphine, because morphine will contribute to spasm of the sphincter of Odie. So morphine is not a medication that will be used for this population. We are going to administer antiemetics to decrease symptoms of nausea and vomiting. And we are going to promote bed rest, however, in a semi-Fowler's position, because if they are lying flat, then their stomach muscles are going to be stretched, and that is going to increase their pain. Diagnostic testing, doctor will do ultrasound. He may order an ERCP. He may order a CAT scan. He may consider a HIDA scan. All of these will help us to visualize the gallbladder, visualize the biliary system so that we can look at the gallbladder, and hopefully we can diagnose with those testing. Administer ordered antibiotics, reduce inflammation, and therefore treat the infection. We are going to administer those bile acid reducers to help dissolve the gallstones. Actigol is something that doctor may consider. MPO status, because we want to prevent gallbladder contraction that will release the bile to break down the nutrients. Again, that is all back to the cystokinin and the sphincter of Odie. If necessary, doctor may order an nasogastric tube, an NG tube to low continuous suction, and he will do this to decompress the stomach and then help to remove the gastric secretions. And this will help with the patient's pain level, and it will also help with the nausea and the vomiting. Patient education. Education will include education about the disease process, that it is manageable, even though they are going through something now. This is something that they can manage. We are going to talk to them, of course, about clinical manifestations, so that if these clinical manifestations present themselves again, that we can get ahead of this and maybe not have them come back to the hospital. And then we are going to talk to them about pain management. So moving on to acute pancreatitis. Acute pancreatitis is characterized by inflammation of the pancreas, and it can be acute or it can be chronic. If acute, patients will present with life-threatening conditions that will require hospitalization, and frequently these patients are in the intensive care unit. They are in the ICU. Pancreatitis can affect people of all ages. If it is mild pancreatitis, there is no end organ dysfunction and a very low mortality rate. Acute pancreatitis can be self-limiting, can be a one-time thing, and patients can fully recover. However, if severe acute patients develop a systemic inflammatory response syndrome, which is SIRS, S-I-R-S, and end organ dysfunction, and again, this is something that we talked about with cholecystectomy, right, and the lap chole. Acute pancreatitis will happen more frequently in males than in females. Well, thank goodness, because up until now, everything has been female-oriented. Chronic pancreatitis. Chronic pancreatitis is a persistent inflammation that will cause scarring and damage to the pancreas and then surrounding tissue. So ladies and gentlemen, listen up for me, and then listen up one more time. Some of the causes of acute pancreatitis is alcohol consumption. Ladies and gentlemen, please pay attention. Alcohol consumption is more frequent in men. There will be a history of alcoholism, and this will increase the patient's risk for acute pancreatitis. Something for women that will contribute to acute pancreatitis is the presence of gallstones. But for men, it is history of alcoholism and alcohol consumption. And then, of course, trauma. Trauma will contribute to acute pancreatitis. So looking at pathophysiology, pancreatitis is the third leading cause of GI disorders that are going to require hospitalization. Cost of care for this population is more than $2 billion annually, so it's a very expensive disorder. Reversible inflammatory process from the release of pancreatic enzymes that auto-digest the pancreas and then adjacent areas. So what happens is the pancreas is essentially eating itself. There is auto-digestion. So auto-digestion will occur when these pancreatic enzymes digest the pancreas and then the surrounding tissue. This may occur as an isolated event, or it can happen more than one time, because we know this, right? We know that if it happens one time, it can happen again. So this can be recurrent. The exact mechanism of the release of these pancreatic enzymes is not well known. So we really do not know why this auto-digestion will take place. Some clinical manifestations. What is your client going to say? What are you going to see? They will complain of a sudden onset of epigastric pain. Sudden onset of this pain. It will be felt in the left upper quadrant or in the mid-abdomen. So gallbladder or chole pain is the right side, correct? So now here we are on the left upper quadrant. It will radiate again to the back or to the shoulder blades, and this pain will be characterized as very deep, very sharp, almost taking their breath away. It will become intense within minutes of eating a high-fat meal. This pain can be constant and severe, and it can last for many, many days. So the patient will complain of severe pain when they are lying flat or bending forward. Lying flat because those abdominal muscles are being stretched, and that is why. Bending forward, it is because of the pressure on the pancreas in the belly. The pain may be associated with nausea, they may have some vomiting, and there may be some anorexia. And then again, please, ladies and gentlemen, please note that when I am talking about anorexia, I am talking about loss of appetite. I'm not talking about the eating disorder. Ladies and gentlemen, please listen up, and then listen up one more time. Alcoholic pancreatitis alcoholic pancreatitis. Symptoms of pain will last from several hours to days after binge drinking. So if there is a long weekend, a holiday weekend, spring break, it's their birthday week, whatever it is, they are drinking, there is increased alcohol intake. Symptoms of pain will last from several hours to days. There will be abdominal fullness from this gas, or they may feel bloated. They may have hiccups. They may complain of indigestion. They may have a fever, and because they have a fever, they may have tachycardia, and there may be some hypotension. So again, when we are looking at this patient, if they have a fever and if they have tachycardia, so the heart rate is going up, the blood pressure is going down, and so when that happens, we think of shock. So diagnosis, what are we talking about? The abdomen will be tender with localized guarding and rebound tenderness. There will be the presence of the Cullen sign. Cullen sign is periumbilical bruising, indicating retroperitoneal hemorrhage. Or there will be gray Turner sign, and this is flank bruising, and this will indicate retroperitoneal hemorrhage. So whenever you see this bruising, either on the umbilical area or on the flank, this is something that if doctor has not examined the patient first and you find it first, this is definitely something that you want to bring to the attention of doctor. Lab tests. Doctor may order a metabolic panel, some hematology studies, some specific tests of pancreatic enzymes, such as the serum amylase, serum lipase. Amylase is an enzyme that will aid in the digestion of carbohydrates. Lipase, however, is an enzyme that aids in the digestion of fats, and so this is the most specific test for pancreatitis because lipase is produced only in the pancreas. So although doctor is going to look at the amylase and the lipase, we are going to pay more attention if we suspect pancreatitis to the lipase level. Ladies and gentlemen, listen up, listen up, listen up one more time. The BUN will be elevated because of impaired kidney function, because your client will be dehydrated. There will be hypovolemia. The AST level will be elevated. There will be damage to the liver cells, and this will be caused by possible bile flow obstruction. So in pancreatitis, when the AST level is elevated, there is damage to the liver cells caused by bile flow obstruction. The ALT may also be elevated, and this could be indicative of gallstone pancreatitis. WBCs, if elevated, will indicate inflammation. And then again, ladies and gentlemen, listen up, and then listen up one more time. A decreased albumin level. A decreased albumin level will indicate a poor nutritional status. Doctor may order abdominal CT scans. He might order an abdominal MRI. He may order an abdominal ultrasound. And the purpose of these tests is to evaluate for the presence of inflammation. We are looking for gallstones. We are looking for a bile duct obstruction, and we are monitoring for distension and the reason for the distension. So, ladies and gentlemen, with pancreatitis, there is a severity scoring, right? Because we have to know how sick the pancreas is. So there are several scoring systems to determine the severity of pancreatitis, and the scoring system that you use or become familiar with will depend upon the scoring system that your facility uses. So Ransom's criteria is a means to measure the severity of illness and the likelihood of mortality. So the patient is evaluated at admission and then again within the first 48 hours. And usually this is a patient that is sick enough with pancreatitis to be in the intensive care unit. They are in the ICU. So if we are using Ransom's criteria, we are going to measure their severity. How sick are they when they are admitted to the ICU? And then we are going to, or sometimes it is done in the emergency room, however they come through. And then we will look at the score again within the first 48 hours. If the patient has a score greater than 3, then they have severe pancreatitis. So a score of 0, 1, or 2 would be probably a mild case. There is also the Apache 2 and the Balthazar CT. These are all scoring systems. With the Apache 2, the severity of illness is calculated on the basis of the first 24 hours of an ICU stay. So again, this is a patient who is sick enough with pancreatitis to be in the ICU. We are not going to score them on admission, either in the emergency room or in the ICU. If we are using Apache 2, we do not get that score until after they have been in the ICU for 24 hours after admission. The score will be based on demographic factors such as age, immunosuppression, their chronic health status, and physiological factors such as fever, their mean arterial pressure, their heart rate, their oxygenation status, their electrolytes, and we are going to also consider the Glasgow Coma score. With the Balthazar, we are going to calculate the results of a CT scan, and that will range from 0 to 10 on a point system given the extent of the inflammation of the pancreas and the surrounding tissue and the presence of pancreatic necrosis. So if we are using the Balthazar, then we are looking at the CT and we are only scoring on the results of the CT. So treatment. Well, we want this client to be NPO, right? Because we don't want to have the release of those pancreatic enzymes that are responsible for the autodigestion of the pancreas, right? We want to slow everything down. We want to stop what we can. There will be IV hydration because we need to maintain the intravascular volume. Lactated ringers is going to be the flavor of choice. It is the most common with this. We will monitor the patient for clinical manifestations of overhydration that can lead to pulmonary edema. So one of the things that we're going to pay attention to with this IV hydration is their breath sounds, right? Because if somebody's going into pulmonary edema, then we are going to hear it in their lung fields. And your client is also going to be, of course, on intake and output. And pain medication because we need to manage their pain. Severe acute pancreatitis with end organ involvement, meaning the heart, the lungs, the kidneys. These patients are managed in the intensive care unit in the ICU because of the potential for hypovolemic shock, pulmonary compromise, renal failure, and GI bleeding. So aggressive supportive therapy is crucial to the recovery of these patients. They may require medications to decrease inflammation, surgical intervention to resect some areas of the pancreas. IV antibiotics are not given to these patients with acute pancreatitis that related to fever, as the fever is something that is secondary to the inflammation. There is no infection present. So after your client is in the ICU and they develop a fever, please know that the fever is secondary. The specific cause will determine the medical management. So If the pancreatitis is alcohol-induced, and we know this, right? We know that it can be alcohol-induced more often in men. We will also treat the patient for alcohol withdrawal because we will see agitation, we will see hallucinations, they will see hallucinations. There will be tachycardia, and there will be a fever. They will be diaphoretic, nausea and vomiting may be present, so treatment may include sedation, hydration, and then nutritional support. Ladies and gentlemen, listen up, and then listen up one more time. Medications. We are going to use opioid analgesics for pain. We may use anticholinergics to decrease intestinal mobility. Histamine blockers, the PPIs, proton pump inhibitors, may be used to decrease gastric acid secretions, pancreatic enzymes, and then antibiotic therapy. Okay, so ladies and gentlemen, as always, there is a controversy, right? Because doctors can never get along. One doctor has one theory, another doctor has another theory, and, you know, everybody has an opinion. So, there is a controversy over antibiotics for acute pancreatitis. Prophylactic antibiotics have been a controversial issue for 5 decades, I'm sorry. So it's been a very long time. And again, not to be resolved anytime soon. Some studies have suggested a lower incidence of peripancreatic infection with the use of antibiotics. However, routine use of antibiotics as prophylaxis against infection with severe pancreatitis is not recommended. So I think it is just one of these things where you're doomed if you do and doomed if you don't. I don't know. So fortunately for us, we just have to take direction, and the decision lies with the doctor. If antibiotics are utilized, it is important that it penetrate the pancreatic tissue to treat the infection, such as Primaxine. So, diet, nutrition. Again, nutrition plays a very big part in pancreatitis. In mild form of acute pancreatitis, we will begin oral intake within a few days of their first onset of pain. They may not require parenteral nutrition, right? Because remember, once they come into us, we're going to shut them down, right? They're going to be NPO for a period of time. So, then if it is a mild form of acute pancreatitis, then they're not going to need parenteral nutrition. Severe acute pancreatitis will be managed with IV fluids and parenteral nutrition to rest. We want to rest the inflamed pancreas and prevent the release of these pancreatic enzymes, right? Because we don't want to set everything off, because it is setting off the release of these pancreatic enzymes that is going to aid in autodigestion and the inflammation process. So, some complications of pancreatitis. Necrotizing pancreatitis. Necrotizing pancreatitis will occur in approximately 20% of all patients with acute pancreatitis. So the mortality rate is about 50-50. It will present 1 or more weeks after the initial onset of acute pancreatitis. It is diagnosed by CT scan, the presence of air and gas surrounding the pancreas. So it is much like gas gangrene. If you remember gas gangrene when you were talking about wounds and infection, it is much the same as that. So it is caused by activation of those pancreatic enzymes that will eat through, again we are talking about autodigestion, the tissue of the pancreas and enter the peritoneal cavity, causing extensive peripancreatic tissue breakdown, more inflammation, and then hemorrhage from the rupture of these surrounding vessels, right? So in essence, the body is eating itself. It is autodigestion. Patients may develop sepsis, they may develop shock, and then multiple organ failure. And there are two types of pancreatic necrosis: sterile and then infected. Sterile areas of necrosis are free of bacteria. It just means that there is no bacteria presence. The pancreas is just experiencing autodigestion. It is eating itself. It is eating surrounding tissue. It is eating into the surrounding blood vessels. Now, ladies, listen up. Ladies and gentlemen, listen up, and then listen up one more time. If infected, if it is an infected necrotic pancreatitis, then we need that is caused by bacteria, then we will treat that with an antibiotic, absolutely. If we can prove that there is a bacteria present. The only way to determine this is with a needle biopsy and a culture, and then it will be treated on the basis of the clinical presentation. So what is going to happen is doctor is going to do a needle biopsy. He is going to obtain a culture. We are going to send it to the lab. If it grows the bacteria, then we know that there is an infection present and we will use an antibiotic. If there is no bacteria present, then we know that it is a sterile necrotic pancreatitis. So, what interventions can we do for this? We can, if drainage or surgical intervention involves debridement of the necrotic tissue and debris via the step-up approach, and this is discussed in your textbook. But please know, listen up, and then listen up one more time. If the culture is positive, we will treat with antibiotics. If the culture is positive, we will treat with antibiotics. So, complications. So some of the bacteria that we may see is Pseudomonas, E. coli, Klebsiella, or Enterococcus. Proteus, Staph aureus, or Candida. Patients with necrotizing pancreatitis may undergo a surgical procedure, and this is a pancreatic resection. An open abdominal resection with open packing and serial debridements will occur every 2 to 3 days. Or we can do a necrosectomy, and this is when we do a resection of the necrotic tissue with lavage or drainage. So pancreatic hemorrhage and then pancreatic pseudocyst. These are also complications. Pancreatic hemorrhage is a rare complication that occurs as a result of these pancreatic enzymes eating into the vascular system and rupturing the vascular system surrounding the pancreatic bed. This is the autodigestion, where the pancreas is eating itself and they will eat through into the vascular system. Patients will experience increased pain, a decreased blood pressure because they're bleeding, and an elevated heart rate. So decreased blood pressure, elevated heart rate. This tells me that my patient is going into shock. Abdominal examination may reveal either Gray-Turner sign or colon sign, which is signs of retroperitoneal hemorrhage. If actively bleeding, then embolization will be required to stop the hemorrhage. So with pancreatic pseudocysts, these are encapsulated areas of fluid that will contain pancreatic enzymes and then pancreatic tissue. They usually occur 4 to 6 weeks after an episode of acute pancreatitis, and then they will resolve just as quickly over several weeks, 4 to 6 weeks, as they came. So they will come, we may or may not know, and then they will leave, and we may never know that they were even there. However, some patients may require percutaneous drainage because the cysts may burst, and then there will be fluid in the peritoneal cavity. We will see ascites, and so we will need to drain off that fluid. If the pseudocyst becomes infected, it is a pancreatic abscess, and this will require percutaneous drainage or possibly surgical intervention. Patients will present with chills, fever, nausea and vomiting, abdominal pain. So we are going to monitor for these cysts rupturing and then watching their vital signs for impending shock. So nursing management, what are we going to do? How are we going to assess this patient? The classic presentation will be a sudden onset of acute pain, unbearable abdominal pain. Other clinical manifestations will include an elevated heart rate and an elevated respiratory rate, low blood pressure, and this is all due to volume depletion. We may see an elevated serum lipase, amylase, and then glucose values because the pancreas is affected, right? And insulin control. We may see hypocalcemia, and this is due to the accumulation of fatty acids. We may see clay-colored stools, and this is due to the blockage of bile into the duodenum. We may see hypovolemia. Your client may be dehydrated. Hypoxia intrapulmonary shunting by collapse of the small alveoli in the dependent airways. So there will be no gas exchange. No gas exchange. We may see pleural effusion, which is an abnormal accumulation of fluid between the layers of the pleura in the lung. We may see clinical manifestations of adult respiratory distress syndrome, ARDS. This is an acute lung injury caused by inflammation of the lungs, causing stiffness and then the inability to exchange oxygen. Your client is on the way to multiple organ dysfunction. So some nursing diagnoses for this population: acute pain related to inflammation, edema, and distension of the pancreas and then surrounding tissue, ineffective breathing pattern related to pain, pulmonary infiltrates, pleural effusions, and then atelectasis, imbalanced nutrition, less than body requirements related to decreased intake and increased metabolic demands. Nursing interventions, what are we going to do? We are going to monitor vital signs. We are looking for a fever, and because of the fever, they may have tachycardia, and this is due to the inflammatory process. We're going to look at their oxygen status. Their oxygen status may be decreased due to the alveoli collapse, or they may have a pleural effusion. We're going to look at their pain. We are going to note the location, the intensity, the duration. They may have pain in the right upper quadrant, which is the head of the pancreas, or the left upper quadrant, which is the tail of the pancreas. This will be related to autodigestion of the pancreas due to the leaking of the pancreatic enzymes into the tissues around the pancreas. We are going to do an abdominal assessment. Palpation may reveal rebound tenderness, and muscle guarding. We may also be able to assess Gray-Turner sign or Cullen's sign. Again, Gray-Turner sign is bruising on the flank due to the exudate stained with blood. And then Cullen's sign is bruising around the umbilicus. We are going to look at the serum amylase and the serum lipase. These may be elevated due to the inflammation of the pancreas. We are going to look at the serum glucose level. Due to digestion of the pancreas, this can lead to the decreased production of insulin, so your client's blood sugar will be elevated, right, because there's no insulin. Nutritional intake. There may be loss of appetite because of pain. The patient may be malnourished, especially if they are an alcoholic. They would rather drink their meals than eat them. We are going to monitor daily weights. We are going to monitor their fluid intake and their output, so they are going to be on I and O. And we are going to monitor the fluid volume status to prevent dehydration. We are going to look at their serum calcium, and then we may be able to note Trousseau sign or Vostek sign. Hypocalcemia, we are going to assess for neuromuscular irritability, right, because calcium in the muscles. Trousseau sign is very, very interesting. If you've ever seen Trousseau sign, once you see it the first time, you will never forget it. And this is when the hand will spasm with inflation of the blood pressure cuff for 3 to 5 minutes. It is very, very interesting. Once you see it, you will not forget it. And then Vostek sign is facial twitching, and this is when you will tap the skin over the facial nerve anterior to the external auditory meatus. And the only person that I've ever seen assess for this has been a neurologist, and actually I have never seen the facial twitching. We are also going to monitor their stool color, and clay-colored stools will be present due to obstruction of bile flow. Nursing actions, ladies and gentlemen, what are we going to do? We are nurses. We are going to maintain NPO status for this patient, and that will decrease the secretion of these digestive enzymes. If ordered, we are going to insert an NG tube, and we are going to attach it to low intermittent suction, and this will be to decompress the stomach, and it will prevent abdominal distension. And if there is diagnostic testing ordered, and there will be, we are going to prepare the patient for testing per the protocol of the facility. We can promote bed rest, but again, in a semi-Fowler's position, or if they want to lie on their side, in a fetal position, because this will help with their pain management, stretching of those muscles, and it will also decrease stimulation of those pancreatic secretions. And we will encourage coughing and deep breathing to prevent atelectasis and then improve their oxygenation status. So medications, we are going to administer analgesics to help decrease their pain. We are going to administer antiemetics to decrease the symptoms of nausea and prevent vomiting. We are going to administer histamine blockers, ladies and gentlemen, histamine blockers to decrease their acid secretion and inhibit this pancreatic enzyme activity. And we can administer sedatives and any anti-anxiety medications, because this will also help to decrease spasm and enzyme secretions. So patient education, because this can be lifelong, right? This can be chronic. They can live with pancreatitis for a very long time. It is the exacerbation that we have to get them through. We need to educate them on appropriate diet and stress intake of small frequent meals and any vitamin supplements. Again, because small, frequent meals, their client will not feel overwhelmed. It is like snacking, it's like grazing, and it will even increase the patient's comfort with their meal. And we need to do a diet history. A diet history can help to identify foods that will contribute to controlling the symptoms, right? So we have to be able to talk to them about their nutritional status. They need to abstain from alcohol because alcohol will account for 1/3 of all cases of pancreatitis. So if they are an alcoholic and if they are in the throes of their disease and if they need to go to rehab, whether it's an inpatient setting, outpatient setting, maybe we need to reach out to a support system, or we may have to reach out to someone, social worker, in order to assist with this. They need to abstain from smoking. Smoking is associated with pancreatic cancer, and it can also adversely affect the healing process. Nicotine will adversely affect the healing process. And then we need to educate them on the disease symptoms, the progression of the disease. When anybody has a disease, especially a chronic disease, they have to know what is coming next. They have to be educated about that so they know what to expect. And if they know what to expect and if they know what's coming, then they can also reach out and inform doctor about what has happened next. We need to educate them on any diagnostic procedures that they are going to and any interventions that doctor needs to do or perform, as well as nursing. Patient education about the disease will improve overall their management and their health. So how do I know? How do I know that I've done a good job in caring for this client, this population? Serious, often life-threatening disorder that will require vigilant nursing management, right? So we need to know that these clients are going to follow up, that they're going to keep on coming back for their follow-up appointments. Potential for sepsis and hypovolemia, monitoring fluid and electrolytes, complete blood count is a priority for evaluating the effectiveness of the treatment plan, right? So I have to constantly be looking at their vital signs because I don't want them to become septic. I don't want them to go into shock. Hypovolemia, I need to know that they are not dehydrated. And then we also need to monitor their lab studies, the CBC, their enzymes, and then we need to monitor fluid and electrolytes. Pain management and their nutritional status are indicators of how the disease is progressing, right? So if their pain is managed and if their pain is controlled, then I've done a good job. If their nutritional status improves and if their lab studies improve, especially their albumin level improves because of their nutritional status improving, then I know I've done a good job. Patients are hospitalized for weeks and then they may require transitional care. They may go to home with home care. They may go to a skilled nursing facility. They may go to a rehab facility to focus on reestablishing their weight and gaining back some muscle mass and to begin making those lifestyle changes that may be required, such as abstaining from alcohol or smoking and, making those dietary changes. Ladies and gentlemen, I know that this has been a lengthy PowerPoint, so thank you very much for hanging in there. If you have any questions, comments, concerns, or issues, please reach out.